This is our third webinar of for our people here at Grady, and I want to welcome everybody to this sort of virtual town hall. I think they've been useful, and we'll continue doing them as long as is necessary. So just a very quick update for people. We passed the 500,000 cases globally, and actually the U.S. will likely pass the 100,000 cases today, and over 100 in Georgia we're about 2,000 cases with 64 deaths. And I just want to show this just because it really highlights how quickly this has progressed. We've gone from 85,000 cases in early March to over 500,000 cases, and the question is why? Well, because this is an exponential growth epidemic, and you can see it took 67 days for the first 100,000 cases, and then 11 days for the second 100,000, 4 days for the third, 3 days to the fourth, and 2 days to the fifth 100,000 cases. So the way we're going was probably going to start going to 1 day or less than 1 day for the cases to double, and that is the challenge, right? I mean, the cases are expanding faster than we can control them. This is the map of the U.S. from the New York Times, and this is a table from the New York Times. And the reason I have it here is because you can see where we are in the state of Georgia, where we have 1,643 cases and 56 deaths. So our mortality, U.S. mortality is about 1.15. Our mortality is about 3.4. So we're in the high end, and the question is why? And that's something that CDC and others are pretty interested in looking at, and have talked to us and Emory and others about looking at the case and trying to understand what's going on. This is data from Georgia. This is as of noon today, and you can see again 2,000 cases, 64 deaths. You can see lab-wise, again, Georgia DPH really still having a lot of slowness in testing. Commercial labs doing a lot better, and you can see the distribution of cases. And again, you can see here the counties, and really is the metro area that is driving most of the epidemic at this point in time, although most other counties have some cases. And of course, this is the big outbreak down in Albany, Georgia, that is really devastating the situation down here for our colleagues at P. Putney Memorial Hospital. I want to show this because today at a call I had, quite frankly, a very knowledgeable, influential person said to me, this is nothing but the flu, and you guys are just, spreading fear, and this is just a bad flu season. Well, this past season was a bad flu season, and you can see that a bad flu season had about 1,300 deaths in the state of Georgia. And if things continue with COVID, we're going to have 27,000 deaths in the state of Georgia. And in Atlanta alone, we had about 700 flu deaths, and we're probably going to have 15,000 COVID deaths if things continue this way. So when people tell you this is flu, you can tell them, no, this is 10 times worse than the flu. And that's what we need to get people to understand. This is not the flu. And unfortunately, the message from the White House is that this is just like the flu, and the flu is just as bad. And we need to really get people to understand that this is different. We're really happy, and we'll talk more about it, that we're doing testing in-house, and the numbers, we'll talk more about them. But our growth here of cases, while it has been going up, it really hasn't been as fast as some of the modeling predicted, in a way that's good. And this is where our cases are here. So, I mean, I think we're doing okay. We could have been, I thought we were going to be in much worse shape by now. I was thinking last week we were going to have about 320 PUIs by now, and we're not there. We have about 280. So in a way, maybe some of the measures that Atlanta implemented are making a difference. And again, talk about at the end of social distancing. We mentioned this over and over. Social distancing will make a big difference. This is some modeling data suggesting that if we do social distancing as a state, our ICU capacity will not be overwhelmed. We really are, the only reason we're doing a lot of social distancing is to prevent our ICUs from being overwhelmed and from decreasing the impact of the epidemic. This flattening the curve is something we need to get everybody to understand, our families, our friends, our neighbors. And I want to just emphasize that on Monday, the mayor, ordered a shelter-in-place order. We were really happy for that. But, we need to get that across the entire metro statistical area, not just Atlanta. So you live in Cobb, if you live in Gwinnett, just talk to your representatives there about how important it is to also put this in place. It would really change what happens to our healthcare system and to our hospital in particular. I want to remind everybody that the Dean's office has put in FOB snacks. They're available 24/7. And we have also wipes there. Come in, get a snack, and just use this as a stress-free zone to thank you for all you're doing. And we'll be talking more about masks later, but this is the kind of mask we have right now at Grady, both N95s medical and the blue, and non-medical or occupational, for construction on the white. They're both just as good. You can use both of them. Please feel comfortable using any of them. And I want to end just by mentioning that if you don't know it, the people in emergency medicine have developed this COVID checker. It's fantastic. Recommend it to your neighbors, recommend it to your family, to your friends. Use it yourself. It's really a very good self-assessment of where you are in risk and what do you need to do, whether you need to get tested or not, or whether you need to go to the doctor or not. And with that, I'll end, and I'm going to ask now Mr. John Halpern to tell us, to give us an update from Grady. John?
Great. Thank you so much, Carlos. And thank you to all of you on this call. Now says we have 375 people on the call, but thank you for the tremendous difference you're making every day in the lives of Grady patients, and equally as important in the lives of Grady employees, as well as your learners and yourselves. A few statistics, and then I'll answer, get into some other issues. But as of this morning, we had 70 PUIs in the hospital, of which 27 had already tested positive. Only 4 of the positive patients are in an ICU. The rest are in step-down or med-surg. To date, Grady has treated 51 positive patients, and as Carlos said, that is lower than we had originally expected, which is good. As I said, 27 of the 51 are currently in the hospital, 22 have been discharged home, and we have experienced 2 deaths, and that may be 3. Of interest to me is that the majority of the positive patients that we have treated at Grady have had comorbidities. Of the 51 positives, we've had 5 with end-stage renal disease, 6 with active cancer diagnoses and undergoing treatment, 17 diabetics and 10 hypertensives. We also this week began testing our employees that were exposed prior to our identification of the patient at the door, meaning they could have been exposed within the ED primarily. We've tested 33 employees that fit that definition, and 3 have tested positive. All 3 are asymptomatic and are being followed, but are at home for the 14-day period. So fortunately, no one is significantly ill. We have been evaluating our capacity, as have the other hospitals. I've talked with Emory leadership and Wellstar leadership today, and all of the health systems, as you know, agreed to curtail elective procedures. And you know, Grady always is full no matter what our bed capacity is. But both Emory and some of the hospitals in Wellstar have hundreds of beds available because they've curtailed those other services. And of course are dedicated to staying that way and are working collaboratively in order to have that capacity in place should it be needed. And I think Carlos in a minute will probably go into more detail around what some projections he and I received today show and when we think this will peak here in Georgia. We are acquiring additional ventilators. We will have 82 ventilators on hand beginning next week. 82, there's currently 50 in use. We will continue to look at that issue and make sure we have what we need. There's a company called MedSend who we partner with, who fortunately supports us with supplying us with that medical equipment. And then one last comment is we continue, like everyone else, to evaluate PPE and availability of PPE. It appears from everything we're doing with our supply chain partners, and we are pulling out all the stops around the world to get what we need, that we are in good shape. There are some items that kind of ebb and flow, but I really hope you will let Carlos or Robert Jansen know if you have trouble acquiring it, because we have it. And so if we have it, I don't want you to run into issues with being able to acquire it. 2 different things, but we want to make sure you have exactly what you need. Today, we distributed N95 masks to all Grady employees working on this campus and in the ambulatory environments out in the community with instructions on how they're to be used. We wanted to provide them with that protection, and also in doing so provide them with more peace of mind. We also implemented this week a bonus system for all Grady employees. Every single Grady employee on their next paycheck will receive additional funds, because we're very sensitive to the fact that we have employees whose spouses or significant others or children have lost their jobs. They're service workers, they've worked in restaurants, their businesses shut down, and there's a tremendous amount of hardship being experienced by our employees, and we want to do everything we can to help relieve that. And so that's my report for the day, and I'll turn it back to Carlos.
Thank you very much, John. We really appreciate you joining us. Dr. Wong, can you tell us about where we are in testing?
Okay, let me see if I can share can I share screen? I said I cannot share screen.
It's at the bottom. You should have a bottom at the bottom that is share screen.
I touch, somehow it won't allow me now.
You have to stop your share.
Huh?
You may have to stop.
Okay, let me stop my share. Now try.
Okay.
Go for it.
Okay. All right. All right.
Okay, good.
Okay, thank you for the invitation. So at least I'll give you some lab update, because I know that on the title it shows the student test kits, CDC, which has some issue. We all know that. I'm not going to detail, especially for their primer and probe. So basically, to go over with what we have at Grady, we've been doing starting with the flu testing. We always have a flu rapid testing on the left side, and also doing the flu PCR for inpatients. That's our workflow. I know some providers have a question and concern about antigen tests or flu tests, but I really want to take out this opportunity to tell folks, don't worry about the antigen because we're using a updated flu immunoassay. It's, as you can see, you don't see the band, machine read it. So that's why this fluorescent detection works pretty well. And I can show you the data from this past season, flu season. As you can see, the green ones is by PCR, the blue one is by the antigen rapid testing, and then the white one is overall. So basically, with performance by the positive rate over the seasons really perform well, similar almost like a PCR. And especially this being performed, demonstrated by the Hughes Spalding testing at the bottom of the screen. You can see at the peak of January, it reached a positive rate of 43%. So that's why to the provider, we're doing the two-step for the inpatient, outpatient, and that works well. And that leaves why we have done for this SARS-CoV testing. Over the years, I've been looking for a few testing, especially for so-called syndromic testing and multiplexing. On the left side, you can see we have this called GenMark test for the respiratory. On the lower right side is the FilmArray by BioFire. And both, as I can show you, with traditional, conventional, common cold coronavirus, it's all being detected. And then we're also looking at other platforms like QIAstat by QIAGEN. As you can see further, you can prove that in the children's or the adults, you can even tell influenza A, whether it's H1N1 pandemic strain. That leaves to us for the issues. When we have a problem with CDC testing back in February 24th, and then as you can see, this is the screen by the FDA EUA approval, and started from the February 4th that CDC got first kit approved. Then this one bring the kind of a buzz for everybody as March 12th, the COBUS testing by Roche is like a capacity and everybody want to jump into it. But what we have here is that we have an Abbott molecular system, M2000, for us all over the years for HIV and hepatitis C. So that's what you can see, maybe there's a 6-day delay. But in reality, we already in talk with GenMark, another vendor, on March the 10th, which I show you we validate for our respiratory testing over the years. So this is the bottom line you can see with Abbott approved March the 18th, and then with GenMark finally FDA approved on the March the 19th. But in reality, we already received the kit for GenMark on March the 16th. And then also for Abbott testing, we already received the kit in March the 19th. So that shows we really worked well in the contract with our testing capacity and with the planning. So that's why I give all the credit for everybody as a teamwork so that we can have a test up and running. And by March the 23rd, we went live at Grady. And as you can see, one example I can show the test is that this was the one test we just have for the Abbott M2000. As you can see, the cycle threshold on this patient is very low, meaning 6.47. That means comes to the positive very quickly. So that's in additional really shows indirectly, even though it's not quantitative assay, that viral load can be very high in those patients. In addition, we also compare to some collection swab as we worry about that collection swab may be a shortage. So we also compare the foam swab, which we have plenty at this moment, so that we can use it. And as you can see on this comparison study on the positive patient, it's almost same. So that gave us further option for the future testing. And then also during the POI workup, we also running by, that's why we should work on very hard on the flu PCR, respiratory virus, and then also in additional QIAstat. As you can see, from March the 11th to March the 23rd, we tested 141 sample, the respiratory sample. All of that, you can see all kind of respiratory virus. You can see traditional, conventional coronavirus. 4 of those we all have seen in our patient population. In addition, we have seen human metapneumovirus, also the common cold human rhinoenterovirus. In addition, we also have some even the Bordetella pertussis on that patient, which is an 80-year-old patient. So that just shows in the future, we really need to work on integrated, not just SARS-CoV-2, but also flu A and respiratory viral panel. And so this is what we have right now. In the traditional, the routine workup, it's on the left side, the M2000 that hold on the large capacity. And in addition, that on the right side, we can do random less than 2 hours on the GenMark. So this is the 2 tests. And then I think even today we got the information that supply is also better than before. So in that case, we can look at other algorithms to doing that. So in general, even if you heard many news with so many tests being FDA approved, and in reality, we got the very early on for the GenMark testing, so we can meet our need. And thus far, 18 of the tests in the for FDA approval, and we already have managed to have 2. Maybe we even can look at further depending on capacity. For that, I will end it here. Thank you.
Thank you, Wayne, and thank you again to the lab. I mean, really the way we stand up testing and the way it's going, and the fact that today you actually validated using a background swab and are telling us that we no longer need to use the swabs that are in short supply, but we can use the swabs that we have plenty of. It's great news. So
yeah,
thank you very much.
They take this opportunity to thank one of the doctor who actually bought his own collection swab for us. Really, thank you.
Good.
Right.
Okay, well, thank you. If you can stop sharing,
Yeah.
I guess we're moving to Dr. Susan Ray. Susan?
I'm here.
Okay, hi.
Hi. So first I wanted to say I'm demonstrating social distancing by not sitting next to Carlos, elbow to elbow for the town hall. I miss sitting next to Carlos. It's very fun. But I realized in the last week, I'm a slow learner, that I've been telling everybody to distance and then I wasn't doing it. So here I am in my own office. So the infection control update is I'm very pleased to let you know that the administration was able to support my recommendation to go to universal masking. And I think that universal masking, meaning all the healthcare workers wear masks when they are in patient care areas, is really important to try to limit transmission from people who don't know that they're sick and from patients who we don't think could be sick. This disease is really tricky, and we're learning a lot from it, and I think we have much more to learn. There's a paper in the published today in the Morbidity and Mortality Weekly Report that outlines an outbreak that happened at a skilled nursing facility in the state of Washington. And the information there is quite striking, demonstrating really how hard it is to detect that someone has disease. And that sort of information is the reason that I felt strongly about recommending universal masking. I want to make it clear that you don't have to wear an N95 mask to have an effective mask. We happen to have a lot of N95 masks, which is really fortunate. And that's because of some really thoughtful and helpful donors in the business community, and the work of our administration to source lots of personal protective equipment. We should be having more surgical masks available soon, but I'm not sure that we'll ever have enough surgical masks to feel that we can preferentially use those. So the idea behind the N95 mask is not that you need to wear an N95 because the other mask is not as good. It is that we have a lot of N95s. And I just wanted to make that clear. I think that's probably all I need to say today.
Thank you, Susan. That's great. Haney, do you want to talk about the emergency room update?
Yeah, sure. So we are continuing to see sort of lower than expected volumes in the emergency department. We have seen typically our volume last year was averaged about 420 patients a day. I think we probably may not break 300 average daily census this week. And last week our average daily census was 333. However, our admit percentage and the number of patients coming in who are in cardiac arrest or are very ill has really spiked up. So we're averaging our normal admission percentage, including our dialysis patient population, is about 22 to 24%. And that number has jumped up in the 30% range. We're also averaging about 4 or 5 cardiac arrests a day, and that's a little bit higher than usual. So we are currently working through with our EMS colleagues how to manage and for this safety of our staff, our cardiac arrest algorithm, which includes some information about airway management and just making sure we're doing it safe. Our EMS colleagues are also going to start calling earlier and utilizing the field termination protocol if it's appropriate. As far as PPE goes, along with Susan and the rest of the ID team, we think we have things safe for people in the emergency department. As we all are, we're certainly not out of, but occasionally are tight on PPE. We've had a number of people come to us with donations for PPE, and we're managing through that. As well as obviously the hospital has done a great job making sure everyone has a safe amount of PPE. We've made it very clear to our folks now is not the time to run in the room without something on if the person's all of a sudden doing poorly, and we've really re-emphasized that. We've also instituted sort of some policing of that from the charge nurses and the managers as well as the ED attendings to make sure people aren't rushing in the room if someone's doing poorly. Perhaps the biggest news more recently, as Dr. Wong mentioned, was the testing. We're working with Susan and her team on the PUI process to make sure that we can help our ID colleagues by sort of taking over more of the testing, more of the decision making. We had a call earlier today to talk about how these tests get followed up on and sort of a pathway for patients who get admitted who are PUIs and patients who get discharged as we start to really try to ramp up more testing. Also today, we worked on our surge process a lot more. A lot of the predictions and everything are saying things are going to likely start getting worse next week. We know that we as a hospital are very tight on beds. And so we're making sure that we have a way to be able to care for the people who don't have a bed yet upstairs, as well as continue to manage our incoming volume, which is obviously expected to spike up. So we're looking very closely at that and should have it finalized by the end of the day. Working with Shannon Sale and her team as well, we are looking at the homeless population and making sure that we can get them tested. Right now, our plan is just to sort of hold them in the emergency department and get a test on them. And then Shannon and her team are obviously working on good placement for them as quickly as they can. We will not be admitting these people to the hospital unless they meet the need for admission. And then finally, sort of the staff well-being part of things. You know, people I think are stressed. It's been very helpful to have our volumes a little lower, and also to have the support from the rest of the hospital system in terms of our staff. Like I mentioned earlier, people are coming back with a lot of donations. People are wanting to buy food and drop off N95 masks and gowns and whatnot. And so that's been really great, and everyone's been really helpful and very supportive. Other than that, people are sort of doing well and getting along as can be. Our partners in security, I want to make sure I recognize, and they've been super helpful as well. And that's about it for an update from the emergency department.
Thank you, Haney. That's terrific. Can we move to Seema, update from the ICU?
Hello, everyone. I am Seema Tekwani, one of the ICU faculty for Emory. In terms of ICU preparations, we have started collaborating with all the intensivists at Grady. We are breaking down the silos, and we have increased our capacity by working with surgical ICU, neuro ICU, and the medical ICU across both schools. At this time, we have a plan in place where we will have all the units staffed by an intensivist and cohort our patients into COVID PUIs and positives in one area, and we've separated them from the non-COVID areas. We have also pooled our resources in terms of nursing, APPs, and residents, where we can rapidly ramp up into our contingency planning on when our ICU capacity exceeds the patient needs at Grady. In addition to looking at our staffing needs, we've obviously talked about equipment, additional ventilators, additional CRRT machines for dialysis. We have process measures in place and safety checks, protocols that can help us quickly take care of a lot of patients very quick in a cohesive, consistent manner. Right now, the patients that we are seeing in the ICU are presenting with ARDS and acute hypoxic respiratory failure. They have a significant requirement for ventilator support and advanced ventilator modes. We have not prone anyone successfully yet, but that's one of the strategies that we're exploring in the care of these patients. For staff well-being, we are doing very intentional periodic check-ins with all our staff. We are doing daily huddles. We are running mock codes. So we are as prepared as we can be in the ICU environment where we see the sickest of these patients. And that's it for now from my end.
Thank you, Seema. Appreciate it. Joanna?
Sure, I'm Joanna Bonsall. I'm the Director of Hospital Medicine at Grady. Not a lot to report at this moment. Our census is a little bit on the low side. I think we're seeing a lot of patients, unfortunately, who are chronically ill, who are avoiding the hospital, and hopefully they're doing okay. A high proportion of our patients are PUI patients and COVID-19 positive, probably about a third to a half of our patients on any given day. We do have a very robust surge plan, both for our census as well as providers being out. And we are starting to work with our critical care colleagues because it does appear clear that the ICUs are going to be hit harder than I think hospital medicine initially. And so we have identified physicians in our group that are more comfortable in the critical care environment, and we're looking to figure out how we can do some sort of hybrid model with an intensivist as well as a hospitalist. In terms of well-being, we're also having daily huddles every morning, which has helped us identify issues that we can bring forward to others, as well as kind of walk through our planning and just overall discuss the situation and just disseminate information. I'm happy to answer any questions.
Thank you, Joanna. I'm going to turn it over to Dr. Nadine Kessler.
Thanks. And can I share?
You should be able to.
Okay. Okay, so I'm going to talk a little bit about some of the well-being issues right now that people have already talked about, and I want to thank my colleagues in psychiatry who have joined the Caring Communities for COVID Caregivers. I had the good fortune to do a grand rounds this week in OBGYN, and they took the comments from the chat when I asked people how they were feeling and made a word cloud out of that, and I think it captures how so many people are feeling right now. Also had them ask about the interpersonal challenges, and here were the issues that came up around that people can probably relate to. And then here are some of the wellness solutions that people are turning to already. And I encourage people to use many of these solutions as well. We've been partnering with the We Care program in the department, and I just want to mention some of the things that are happening. Dr. Erica Lee is coordinating our efforts to hold regular support meetings or calls for all of our inpatient staff. We've been doing those 3 times a day since Tuesday. We're going to do them twice on the weekends. Next week, we're going to go down to twice during the day because we've had somebody from our team on at 1 a.m., but we haven't really had a lot of staff on the call. And we're also doing regular outpatient, regular support calls for our outpatient staff as well. We've also had support meetings for specific departments and teams. Yesterday, for example, we did 12A, 12B, 11A, and the cath lab. We have the MICU and the SICU scheduled for early next week, and we're happy to do these for specific units, teams that are particularly impacted right now. We're talking to them about building in a team self-care structure, a mindfulness activity, for example, a gratitude exercise. Many of the teams are having prayer circles before the shift starts. Really highlighting the importance of a moment of silence for each COVID-19 patient who dies, and including the family whenever possible in these online to make that possible, so that we don't lose sight of the people who are dying as individuals. We're also continuing to hold regular virtual support groups for residents from multiple departments, and you can see the departments. Some groups of attendings have already requested support groups as well, and we're happy to do those. We've already given some grand rounds and more are being scheduled, and happy to do those on sort of thinking about the mental health consequences and effective ways to build resilience and cope optimally through this time. We've already developed some tip sheets, some are already online, and we're handing those out. They're available. We have more that we'll be able to launch this weekend, and even more in the works. And here's how you can reach me for assistance that's needed. We have a team that's available to help out to you, to your staff, to your units 24/7. And before I end, Carlos, I want to just take a moment of gratitude for the leadership of the people on this call, who are speaking on this call, because we're all looking to amazing leaders, and we are really fortunate to have them at Grady. So thanks to everybody for being such incredible leaders during this crisis.
Thank you, Nadine. Appreciate that comment. I guess the last presentation, the last commentary is up to Dr. Lennox. So Jeff, can you give us some closing remarks before we open up for questions?
Sorry, I was on silent. Yes, a few things. First of all, I know that we're running into issues with nursing homes and skilled facilities, et cetera, not taking patients back until we have a negative COVID swab on them. And so we need to plan ahead. Even if somebody's completely afebrile and has no symptoms, they've been requested that we do that before we place them. And, I don't know if there's any cost utility to this practice, but it's what's being demanded of us. And I think, we've got surge capacity, as Seema talked about, with the units. I was on a call today with providers from New York City, and even in New York, they currently have adequate capacity for their ventilators, but they're reaching the limits of what they have. And they're continuing to see a growth in ICU and regular admissions. And so they're anticipating within 1 to 2 weeks, they'll be in a crisis for ventilator capacity. So the lesson for us is we're a few weeks behind them. I think we need to take what time we have now, where we're in sort of a sweet spot where we're getting experience treating cases, and get ready to be inundated, like New York is maybe a month from now, unless this social distancing really does have the effect that Carlos showed. Maybe we'll escape and only have a really, really busy next 4 weeks and not come to a crisis point. And that's why I think we need to all hope for that and try and encourage everybody to socially distance. Because in New York, it's going to be really bad in the next 2 weeks based on where they stand now. Thanks.
Thank you, Jeff. And now what we're going to do is, as we've usually done, is we'll open the chat box and we'll start answering your questions. And I know some people send questions ahead of time, but somebody said it's important to tell the U.S. is testing more than any other country. Yeah, the U.S. still needs a lot more testing to do. And here in Georgia, we're still pretty slow in testing. I think in some places they are. I think it's sort of a patchwork. In the AD, providers have been given 2 N95 masks to use until they are unusable. If Grady has lots of N95 masks, when will those be distributed? Well, I think I'll leave this to Susan and John, but I think we want to give 1 per person and then you can get it replaced. Susan?
Yes, the idea is that you of course should get a new one when the one that you're using is no longer usable. And you can turn that in and get a new one. I've been trying to work with administration so that we have a clear process for that. And I have to say, I can't speak to that off the cuff at the moment. But if you are without a mask and your mask is no longer working, please send me a message or call. Well, you can send me a email.
I think Susan, I'm having a Constance Nagel in my office to deal with that, so you don't get overwhelmed with that. They can send an email. We'll put it in the email. They can send an email to Constance. We'll get masks for people.
Okay.
Okay. So there's a question here. Hi, if I'm wearing a surgical mask, and are we changing it after seeing each patient?
No, which is really counterintuitive. And I would have not predicted that I would tell you that a few years ago. But the idea of the surgical, if you're caring for patients who do not have COVID or are not suspected of having COVID, and you're wearing a surgical mask, which is what I would choose to do if I had one and was caring for patients, because they're more comfortable. You can wear it as long as you'd like, and then take it off in order to eat, etc. And if you can make it last the whole day, that would be really great. So I know that's kind of vague, but I just want to give you the idea that the mask that you wear while you're caring for patients and interacting with others in the hospital, we're trying to limit the things emanating from you that might emanate when you talk or laugh or interact with others. And the mask is meant to be a barrier for that.
Okay, good. Next question. If I go from one PUI to the next, do I need to change my mask?
You do not. You do need to clean your hands and change your gown and gloves.
Okay, next. There's a question here about clinical trials, and next Friday we'll probably give you an update of what we are in clinical trials, but we're working very hard to try to open the remdesivir trial hopefully next week, and got a couple of other trials, but for next Friday we'll talk about clinical trials. And one question, how are we triaging patients who develop symptoms while in the hospital? We have several patients who develop one or more of the following: new cough, ground glass appearances. So they're probably having nosocomial acquired COVID. What are we doing about this?
I'm concerned about nosocomial COVID, and that's why I want to do universal masking and encourage hand washing, etc. To good adherence to standard precautions.
Okay. Question again, Susan, for you. When can positive providers return to work?
A provider can return to work based on their symptoms, not based on so there are 2 algorithms. If you read in the literature at CDC, there's something called a test algorithm and a symptom algorithm. I think we're not using test to clear someone to come back to work. Their symptoms are what matter. So 7 days and 72 hours symptom free, whichever is longer.
Okay. Good afternoon. How can we download all the information slides that you have provided? We will make them available. They go in my email later on today, and they go to everybody. So question about masking. When will universal masking go into effect? As far as I'm concerned, it's going into effect right now, right? Correct, Susan?
That's correct.
Okay, so the question is the use of mask in clinical areas still recommended or is it required?
I don't think we're going to have mask police. I'm very strongly encouraging it. You're encouraged to wear it the whole time you're in the building, as a matter of fact, but you're really encouraged to wear it while it's recommended while you're caring for patients and in patient care areas.
So it's a little bit like we're recommending hand washing, right?
Yes, I guess I would say it's a very, very strong recommendation.
Yeah. So people are asking, well, just like the nursing homes are requiring us to do a test, are we doing the same? Dialysis units likely going to do the same. Are we going to do the same there?
Well, we've already seen some a few dialysis patients that have COVID, and we're notifying their dialysis clinic because I think they need to be concerned about, what might be happening there. But I don't think I haven't heard that a dialysis center is asking us to clear someone.
So is it legal for SNFs to refuse taking patients back? I don't know if it's legal or not, but I think it's inappropriate. And I think, if we're having those kind of issues, I think we need to bring them up to Dusty and have him work with those. So we need to communicate those to Dr. Sanders. A general question, how are there any accurate models being developed to estimate the number of cases given the regional variation in testing? I'll send you a link. The Institute for Healthcare Metrics and Evaluation just released some modeling that I think is pretty interesting to look at, and I'll put it in the email. Okay, a negative test does not inform us of the status from sample acquisition to result. Could the receiving center still decline to accept unless the patient is kept isolation from testing to discharge? Well, I think a negative test doesn't mean the person does not have the disease, right? So we just need to use our clinical judgment, but a negative test may be useful to discharge somebody. A lot of people in Atlanta are starting to make face masks. Is there a role for this? So Susan, how about the thousands of people that are saying they're sewing masks and they're doing things like that?
I just got a text from my daughter that my friend Laura dropped off a mask for me that she made at my house. I'm not sure. I'll cherish it because she made it for me. I'm not sure what the utility is.
Okay.
That's being considered.
We're getting requests from nursing homes to clear patients with COVID testing. How do we handle this?
It seems we're going to have to do it. And I think one of the big questions for me has been whether if we're collecting a test, then should we move the patient to isolation? Because it seems a little bit inconsistent to be looking for that disease when you don't have a person in isolation. But I don't think we're going to move everybody to isolation to collect a COVID test when they're asymptomatic. I also think we might find some positive tests that surprise us. So it's a sticky wicket. I guess I'd rather know about a positive test than not.
Right. So for now, who's allowed to conduct nasal swabs for coronavirus testing? I understand the ID service is very overwhelmed. Should we suggest a point person on each team as a dedicated sampler?
We're trying to train everybody who's willing to learn. So that's a great idea. And the administration is also looking at this issue in a more central way. There have been lots of healthcare workers who have willingly and enthusiastically come to learn how to swab. So there's no lack of enthusiasm and interest. But there does need to be a coordinated effort to meet the need when it arises. And that's what we're working on now.
Okay, any, yes, sir?
We have had a number of of bad samples. And it's been a concern because we're using up reagent and test kits on bad samples. And so I do believe there is a plan in place to consolidate the swabbing and collection of specimens, and we'll talk about, we'll make sure that you and Susan have that.
Yeah, no, I appreciate that. And I would tell you, I've said this over and over, and Susan and other people know it. A nasopharyngeal swab is not an easy swab to obtain. You need to know what you're doing. And as somebody said to me once when they were getting one from me, if you don't feel like you know, they're going into your brain, if you don't feel uncomfortable and you don't have a tear coming out of your eye, it's probably not a good sample. So it is not something that you just stick up somebody's nose. It's really quite a process. So yes, I agree that we need trained people. This is not something that you can just obtain. And we have had many negatives that I'm not particularly happy about. So John, a question for you. Any interested plans for checking temperature at the gate? The VA is doing this.
We are looking at, you mean for all employees, I
Correct.
assume that means, because we're already doing everyone else entering, but we are evaluating moving to doing that in the next week.
Okay, many of us are going home to family and friends. Each of us have developed our own plans of what to do to prevent taking infection home. Are there any consensus best practices to keep them safe? I'm not aware there are, but I think we could potentially, I know who sent this question. I would encourage us, let's plan on developing some lessons learned and safe practices that we can teach each other. I think it's actually a very good point, and I would follow up with that person about maybe taking the lead on this. A question, how long will it take for employee health to contact an employee who has exposed before a patient was placed on PUI?
Employee health is not, we are not as a system conducting systematic contact tracing. I think that's sort of what you're asking.
Yes.
At this time, we don't, well, we aren't.
Any plan for any attempt to test healthcare workers for antibodies?
There's a lot of protocols getting underway to do serology assays. Some of it is to validate existing assays, and some of them are to develop new assays. So yes, there will be a lot of that happening. I'm not sure how long it will be before it becomes actually something that's of clinical utility.
So here's one that this is like a fastball down the middle for you to hit a home run, Susan. I know your answer is something you like to preach. There's a disparity between what Emory healthcare policy for masking during routine patient care versus a strong suggestion from Grady, and this is causing confusion. Can you clarify?
They are different. That's the clarity. I think Emory may be getting ready to change theirs.
I think everybody's changing theirs. Piedmont has changed theirs, but I mean, Susan, I want you to emphasize what you always said to me and to others. Hospitals have different policies, and they don't necessarily mean they're wrong.
Right. The thing that I tell our trainees every year when we teach them about infection control, which nobody's usually very interested in, is I start out by saying, you're going to go to a bunch of different hospitals and you're going to learn one thing at one hospital, and then you're going to go to another hospital and they don't do that. And you're going to say, what's wrong? I thought we were supposed to do this. And what I'm going to tell you is both hospitals are right. Hospitals have plans that are based on their resources, the patient population, the building, the kinds of things that are wrong with people. And there are many right ways to do infection control. Everybody in infection control agrees that we should clean our hands. Everybody in infection control agrees that we should cover our coughs. Those are universal tenets that we all agree on. And beyond that, there's actually a lack of evidence for many of the things that we do. And that's one of the reasons for a lot of the disparities.
Okay, a question came in. Does universal masking apply to Hugh Spalding Hospital?
I don't know. I hadn't thought about that. That's a great question.
Okay, we'll try to answer that. For interaction with patients who have no symptoms that are not under suspicion, not PUIs, are we supposed to be wearing a gown?
No.
No. Chloroquine hydrochloride is hypothesized to be effective at least partly on the basis of epidemiological observations. Are there any Grady populations that are not, that this should be applied to?
You know, Carlos, the data on chloroquine and hydroxychloroquine is so weak that I even hate to use the word data in the same sentence. And the Department of Health and Human Services has formed a panel to provide guidelines on treatment, and that panel is supposed to issue its first recommendations next week, and then update it probably at least every week and possibly every 2 weeks if there's not more data. So there will be some guidelines coming from the NIH next week.
And I would say Jeff has been in a lot of those calls, so he knows a lot of the information that is out there. Is there a shortage of disposable stethoscope? If so, what is the protocol for cleaning our own stethoscopes?
I don't know if there's a shortage of disposable stethoscopes, but I don't think they work very well. And the protocol for cleaning your stethoscope is the same as is being distributed for cleaning your goggles.
Yeah.
To wipe it with a Sani wipe.
Okay, there's some questions about codes and protocols for codes in COVID-19 patients, and I can tell you that there is maybe critical care wants to talk about this, and if not, we'll table it because there's a committee that is working on both protocol as well as what you probably heard out there about DNR in patients, and there's a lot of ethical issues to be discussed. But Seema, do you want to say anything about codes?
Right now, we are really working on our teamwork for code and how we respond to them, because I think that's a big source of the stress when codes happen. But in addition to that, yes, we are thinking about what we would do in scenarios where doing CPR would not be appropriate for multiple reasons. And hopefully we'll have something to look at around next week, halfway.
Okay, thank you.
Carlos, if I may just chime in a little bit on this as well. We're working on it and obviously sharing with our ICU colleagues as well. And I think one of the big steps I think we're all want to take is not having 50 people in the room when there is an arrest. And then working really hard throughout our department on how to manage the airway to prevent aerosolization during codes and cardiac arrests. So, and we're obviously working very closely with critical care on this.
Thank you so much.
That also answers Dr. Klein's email about this.
Thank you, Haney. I really appreciate that. There's a question here about there are reports of reinfection. Is there a basis for this? Or you know, I think there may be reinfection, but I think we are pretty confident that actually you develop immunity to this virus, and that's what the data seems to suggest. But again, a little more data is needed. But what's coming out of China suggests that there may be reinfections here and there, but then it's not common that you actually develop antibodies. How long you're protected for, I think, is a different question. I think we've pretty much gone over all the questions. So unless there's any, unless there's
Dr. Del Rio, this is Seema here. I want to add something to the code. So in working with the ICU teams, ED and critical care CPR committee, we have come to a decision that in order to prevent a very high number of healthcare workers responding to our codes, all codes in PUIs and positive patients should be announced as a restricted code blue. That will maintain a system alert that only few people on the unit will respond and not everyone in the hospital.
Okay, terrific, thank you. I think there's a question here is I'm currently out for employee health for 7 days. My 7 days ends tomorrow. However, I called today and was told someone will call me back at the end of the day and allow me to come back. If no one calls me back, should I come back on Monday?
I can get, are you talking about Emory or Grady Employee Health?
I have no idea because I can't tell from this, but I'm gonna answer to this person to please contact you directly.
Yes, contact me.
Okay, and then there's a question here, question that I think is pretty interesting is about, can you comment on whether this virus is spread through droplets or is it airborne? I mean, I think most of us believe that this is mostly airborne. I think that it could be aerosolized when we have procedures that there's a lot of aerosolization, for example, BiPAP and you know, sort of doing an induced sputum. But other than that, the biggest issue is droplets. I can tell you also there's a lot of data now, increasing data suggesting that really the fomite, the inert object transmission, the hand transmission, may be actually a lot more important than we think. So again, we keep on harping on masks, but I really want to harp on hygiene and cleaning our hands, because a lot of what we've learned, and there's some really interesting studies and as well as videos, is how much we touch our hand, how much we touch things, how much we touch our faces, and how much that may be contributing. And in fact, the viability of this virus in surfaces may be a lot longer than we predicted. And there's an interesting study that I can put some data in our next conference. But you know, it may be the persistence of this virus in innate surfaces may be longer than we actually thought. I don't know if anybody wants to add anything to that. So rather than worrying about the airborne or not airborne, I tend to worry more about what we're touching and what we're doing when we touch our hands. Well, you know, I think at this point in time it's almost 5, and I appreciate everybody who participated. I hope this is useful. We'll make a summary of the questions and the slides and get them to everybody probably by late today or tomorrow. And again, have a good weekend. Thanks everybody for what you're doing. Thanks everybody for your dedication. And please let us know, myself, anybody, if you have, and Mr. Halpert, Dr. Jensen, if there's any issues or concerns. Everybody's really working very, very hard to both ensure patient care and most importantly also ensure the safety of our healthcare workers. So with that, we'll end and have a good weekend.